Welcome in, everybody. We'll give people just a few more minutes to join and then we'll go ahead and get started. Alrighty, I think we'll go ahead and start. Thank you so much for joining us this evening for our equine seminar series. Before we start tonight's talk, we'll do our usual housekeeping items. We'll highlight next month's seminar, which will be our final seminar for the fall semester. This will be held on Tuesday, December 16th, and the presentation will be by one of our equine-focused pathologists, Dr. Mason Yeager. We're also busy planning our spring seminar series, so keep an eye out on your inbox for updates on our speakers for the spring of 2026. As always, we will save some time for questions at the end of the presentation this evening. Please remember to use the Q&A tool to ask your questions as they arise, and then we'll answer a few of these live at the end of this evening's talk. It is now my pleasure to introduce tonight's speaker, Dr. Katharyn Mitchell. Dr. Mitchell graduated from Massey University in New Zealand and then practiced for several years in Australia. She completed her residency in large animal internal medicine here at Cornell University, and then she completed a PhD in equine cardiology at the University of Bern in Switzerland. And Dr. Mitchell is currently an assistant professor with the Large Animal Internal Medicine Service here at Cornell. And with that, I'll turn it over to Dr. Mitchell for her presentation on equine arrhythmias.
Great. Thank you, Dr. Nickelbine, and welcome everyone to this chat tonight about if you're a vet, here's an irregular heartbeat. What should you be concerned about? What does that mean for you and your horse? And so hopefully we'll talk about some of our common causes of irregular heartbeats and the ones that we need to worry about and the ones that we're kind of less concerned about. So I will hopefully be able to get our slides to advance. There we go. So just to start maybe at the beginning, why do I particularly love hearts? And so this is a picture of me here when I was, I think, 6 years old at my primary school in New Zealand, and I was giving a talk to the whole class about myocardial infarction, so heart attacks, and we were discussing how the heart works. And so I've always been really, if you like, in love with hearts, and from an early age, because my mum worked with people who were really sick. She was a nurse and she worked with heart disease people in the ICU. But I actually, when I was 15, I actually developed an irregular heartbeat of my own. So I was a tap dancer. And I was tapping away, practicing my routines, and I actually became really short of breath and fell down. I actually had collapse, and because I had an arrhythmia, and my heart would beat really fast, sort of 200, 240 beats a minute. And so I luckily grew out of my arrhythmia, and I didn't need any specific treatment for it. But I think that's part of the reason why I'm really interested in the rhythms of the heart and the irregular rhythms of the heart. And I'm glad that this at least I didn't need any treatment for my arrhythmia. So we just start with a little bit of some background knowledge about the horse heart in general. So some of you might have seen this slide before, but there are some pretty interesting facts about the horse heart. It's a fairly extraordinary pump, and it pumps around 40 liters or about 10 gallons of blood about your body every minute. So that's what we call the cardiac output, which you might hear us talk a little bit more about as we go. So the amount of blood you pump per minute is really important, because that blood has to go to your brain and your muscles and your organs to keep them oxygenated and functioning normally. The average heart for most horses that weigh about 1,100 pounds, give or take, is probably in the order of around 1% of their body weight. So around 10 or 11 pounds would be the average size heart. So for those of you who work like me in the metrics, that's about 5 kilograms. And so that's a pretty enormous kind of size if you think about it. And the most amazing thing about the horse is that at rest they can have a really low resting heart rate. So they can have a heart rate that's in the 30s often, but at exercise they can actually accelerate their heart rate to the same as what we do at peak exercise. So they can go, in excess of 220 or 230 beats a minute when they're really galloping flat out. And so that range of heart rate is really kind of extraordinary. And even more extraordinary, really, is the fact that then if you think about how much blood you're pumping during exercise, that could be upwards of 250 liters or 66 gallons of blood that you're pumping around your body every minute. So your heart has to work really hard. The horse heart has to work really hard in order to be able to do that job, and to be able to keep the horse at peak performance. And when we think about just some basic anatomy of the heart, we think about there being two sides of the heart. We think about the right side of the heart and the left side of the heart. We think about the right side of the heart taking the blood from the body and then pumping it to the lungs where it gets the oxygen. And then we think about that blood coming back into the left side of the heart from the lungs, so now carrying the oxygen. And then the left heart's going to pump that blood out the aorta, and then that's going to be distributing the blood to the organs and to the brain and to the muscles. And so that when we talk about the heart, we talk about if it's affecting the right side or the left side. But when we think about arrhythmias, really they're affecting both sides pretty equally. So most of the time, we actually divide our arrhythmias into what we call supraventricular arrhythmias. So the little chambers at the top of the heart, the atria, or ventricular arrhythmias, so affecting the big kind of pumping chambers or the bottom chambers of the heart. So a little bit different when we're talking about arrhythmias. And then if we think about those arrhythmias or those irregular heartbeats, so when we talk about the normal rhythm, it's very regular. And the normal rhythm is actually controlled by what we call the sinus node. And the sinus node is sitting in the right atrium, and it's constantly going and depolarizing and beating over and over again all by itself. It's a piece of tissue that knows that it just has to constantly beat over and over again. And so it has what we call pacemaker activity. And so the sinus node is really the pacemaker of the heart. And then from there, the electrical signals spread across the atria, and then they kind of join up together at what we call the AV node, and then they go down the ventricle and around the sides of the ventricle, and that's how the heart depolarizes, and the electrical signal gets sent across the heart. And then from there, the electrical signal makes the heart squeeze. So if you have the electrical signal, then coupled to the squeezing, then that's how the blood gets pumped out of the body. And so we see that a little bit here. If we get the pointer, maybe we can get the laser pointer. We can see this is the heart here, and these yellow signals are the electrical signals. Basically, this is the sinus node up here in the right atrium, and then that spreads across the atrial tissue. Then it collects here at the AV node, which is kind of the central point in the heart, and then it goes down the center of the heart, down the septum of the heart, and then up the sides of the ventricles. And so that's what this picture here is depicting. And then when we look at that on an ECG or an EKG, we can see those electrical signals in a picture. So we can actually see those atrial signals in what we call a P wave. And then we can see that ventricular signal is what we call a QRS. And this is the big guy here in the middle. And then we have what we call the recovery or the repolarization that's giving us our T wave. And so when we're looking at the horse EKG or ECG, sometimes people will be like familiar with what it looks like in people or dogs and cats, and it will look upside down. And that's because the way the horse heart depolarizes or spreads the electrical signal is a little bit more in a downwards way than it is in humans and dogs and cats. So they have more of an upwards kind of look to that QRS complex. So can take a little bit to flip that up in your head when you're not quite used to looking at that. These beautiful, pretty pictures here in the middle are actually some maps or electrical. This is mapping the electrical signal inside the heart. So these are what we call 3D maps of the horse heart. which have the anatomy and then the electrical signal kind of overlaid. And these are some of the maps that we've been creating here in my lab over the last couple of years. And this is the top one here is a map of the right atrium. So you'll be able to see on this left-hand side, you'll see the bright red spot. That is the sinus node. That is where the electrical signal starts. And then you'll watch it spread as we play this video. And then the right-hand side, this is the voltage. So this is how strong the electrical signal is spreading across the heart. And you'll see that everything should be a nice purple color. That means it's nice and healthy. And then up here where the atrium is, the tissue of the heart is ending, you'll see that it kind of turns to red, and that's because there's no electrical signal out in these tissues anymore. So what we want to see is nice and purple. And so when we watch that play, we'll be able to see how the electrical signal spreads from that sinus node across that atrial tissue and goes from that bright red kind of center out to the more periphery where it's kind of lighter blue. That's happening a little bit later. So that's how the heart is spontaneously depolarizing or sending that electrical signal out into the tissue, and then the tissue will contract as a result of that electrical signal. So that's a normal sinus node and the normal way the electrical signal spreads across the right atrium. And then down the bottom here, we'll actually see how that signal comes from the right atrium and then down to the ventricles. So here we have a right ventricle and a left ventricle. We're actually missing the left atrium in this picture just because we haven't, this particular horse, we don't have a pretty picture of the left atrium. But we'll see the electrical signal kind of go from the atrium and then burst out and go down to the ventricles. So we can see that kind of bursting of color through to the ventricular tissue and getting the signal. And then that's when the ventricles would squeeze and then pump that blood out of the body. So these are nice normal examples of how the electrical signals would spread across the normal heart muscle. When we think about arrhythmias, so irregular heart rhythms or irregular heartbeats, this is kind of a lot of things on the slide, and I don't expect you to read all the small details, but what I think is important to realize is when you have an irregular heart rhythm that starts, you kind of need to have a trigger. So you need to have something that starts that irregular rhythm. And then you need to have what we call substrate, which is the kind of tissue that you have that is arrhythmogenic, so is promoting arrhythmia. And then you need the perfect electrical conditions that kind of promote the arrhythmia. And so without these three things all together, you might have just a single premature beat or a single arrhythmia, but you might not develop a more long-standing arrhythmia. But it's when you have this perfect trifecta of things where you have the abnormal tissue, you have the trigger that starts it, and then you have those electrophysiological changes, the perfect electrical conditions, that then you become with a more sustained or more permanent arrhythmia. And so we're always looking at this to see, okay, just if you have a trigger, do you also have underlying substrate or heart disease that might, make this more likely to become a problem? Or are you sick and have, physiologic changes to your heart muscle where you're not delivering enough oxygen or your electrolytes aren't great, that is maybe conducive to developing an arrhythmia? And so we need to kind of think about this triad of things all together when we're looking at our patients. So how do you know if there is a heart problem? In particular, how do you know if there's an arrhythmia? And so we could ask ourselves some history questions. We could look and see if there are any breed predispositions to arrhythmias. So the only one that we really know about is in standardbreds. There's a little bit of a hereditary look to atrial fibrillation, but the rest of the arrhythmias, we don't really have a clear breed predisposition. So we have some suspicions in some breeds of different things, but we certainly don't have evidence for right now. But the standardbreds and atrial fibrillation is at least documented in a couple of studies. One of the single most important things, I think, in our history is when was this animal last normal? So have you really, when your vet last listened to the heart, did it sound normal? Did it sound regular? And then when it is sounding irregular or abnormal now, how long has that been? Trying to get a feeling of how long things have been going on for can be really important when it comes to arrhythmia, because a lot of the outcomes of treatment of arrhythmias really depends on how long they've been going on. And then certainly we'll be looking for any signs of a lack of energy, if the horse is having a longer time recovering, if the horse was performing really fine and then now all of a sudden is not performing well. Is there been a change in performance? Can we really pinpoint the day where or the week where things really didn't feel right anymore? And then some of the more severe things will be actually causing things like colic. We'll see some horses that present for colic and they actually have an abnormal heart rhythm. And then, the things that have been going on more long-standing, we might see weight loss. We might have a cough depending on the other things that might be going on. Younger horses might be a bit slow to keep up with their pasture mates, and we certainly see arrhythmias in some of our younger horses. It's not just a middle-aged to older horse thing. And I think maybe more than other kinds of heart problems, arrhythmias are much more likely to cause a performance limitation because so much of the beating of the heart is really, if the beating of the heart becomes irregular, you're not going to pump enough blood around your body and you're going to have trouble getting oxygen to your tissues. So you're going to see that in a reduction in performance, probably more than some of your other kinds of heart disease. So when we do our exam, we are going to have a really close listen to the heart, and it's really hard sometimes if you only listen for a very short period of time to hear some of the arrhythmias. So if it's a sustained arrhythmia that's been, it's there, every beat is abnormal, then you're going to pick it up even if you just listen for 10 or 15 seconds. But if you're listening for individual premature beats or individual pauses, you might need to listen for longer. So we really recommend, I'm listening to these horses for 30 seconds or a minute or even sometimes longer to try and, determine if there's an irregular heartbeat. I'm also going to be feeling the pulses and I'm going to be looking at the rest of the heart. So thinking about, is there also a heart murmur in addition to this irregular rhythm? And I'm going to be trying to decide if the irregular rhythm is what we call regularly irregular, so if there's a pattern to it, or if it's what we call irregularly irregular, where there's no pattern to it. And I can't really predict what's going to happen next because that can help me tell, which of the main possibilities this might be. And certainly going to be looking at the way the horse is and how bright it is and how it's doing in its overall kind of situation. If it looks like the blood's pumping around the body well, or if it looks like maybe the heart's not doing a good job pumping that blood around the body, is the horse kind of dull? Does it not look like it's interested in its food? Is it kind of shivery and shaky and sweaty and uncomfortable? Is it colicky? Is it agitated? Those kind of things can all be signs that maybe there's something underlying going on with the heart. And we certainly are going to use our stethoscope, but we can also really quickly record an ECG or an EKG in some of these cases. And if you hear something or somebody hears something abnormal, it's always a good idea to try and get a recording of that, because maybe if you come back in 5 minutes or 10 minutes or tomorrow, it might sound different. And so we have a lot of really cool pocket devices. So this one here is our Cardia Mobile. You can actually buy these. They're designed for humans to detect their arrhythmias. So you can just put your thumbs on it and it'll record a ECG to your smartphone. You can put that on the side of the horse's chest with a little bit of water, and then you can actually record an ECG of the horse as well. And we have a lot of owners who are, if their horse has got an arrhythmia or had an arrhythmia, they'll buy these little devices, and then they'll be able to monitor their horse at home just to kind of keep an eye on things. And then, of course, if we need to do more intensive ECG or EKG recording, we can certainly do that. There's a number of different devices that you can use. You can use there are girths, there are saddle blankets, but there's also the kind of more traditional cables and machine as well that you can use to record the arrhythmia. But until you record it, it's really hard to say what kind of arrhythmia it might be. So the key to figuring out what it might be is to really get an ECG recording. So why or when should you be getting your horse's arrhythmia checked out? And I think one of the biggest things is to figure out if there's anything dangerous going on. We want to be making sure that it's really safe for you, for your horse, to be doing the job that it's doing. And so one of the biggest parts of what we're looking for is to try to determine if there's anything dangerous or unsafe happening with the rhythm. We're also going to be wanting to see if it's just an arrhythmia, if you like, just an arrhythmia, or if there are underlying kind of structural changes to the heart, that the heart is maybe enlarged and so there's more kind of heart substrate there. Is there a leaking valve? Is there something else going on that maybe will change how we treat that horse and maybe change the prognosis for the arrhythmia? And then we also want to look and see, how is the heart doing? Is it doing a good job squeezing? Is it pumping that blood around the body in an appropriate way? Or is it going too fast and it just can't fill and therefore not have enough blood inside the heart to squeeze each time? Or is it really like incoordinated squeezing? Sometimes that happens. And so it's really important to sort of have those kind of things assessed. From a safety standpoint, I think we think about that from just, the handling and the riding or driving kind of perspective. But we also have to know, is this a safe situation for the horse to be sedated or have anesthesia? Or have other things that are going on. So a lot of arrhythmias are really well tolerated from a sedation and anesthesia point of view, but not all of them. And so it can be really important to get that information ahead of time. And then, of course, if you're having a performance problem and you're not really sure, is this arrhythmia the cause of my poor performance, or is this arrhythmia likely to cause poor performance? Will there be any kind of longevity? Will my heart not do so well in the long term if I have this arrhythmia for longer periods of time? And then, of course, the big question is, if we're buying this horse, if we're selling this horse, what does that mean if we have an arrhythmia that's going on? And so this is often why we want to get our arrhythmias checked out. So we'll see if we can hide this thing up here. I don't know. We have hide the video panel. There we go. So which of the arrhythmias are important? So I'm not going to talk about all the arrhythmias today. I'm just going to focus on a few of the most important arrhythmias, the most common arrhythmias that we see, maybe the most concerning arrhythmias. And so probably the one that most of you are familiar with is atrial fibrillation. And so you might have heard about this arrhythmia, and you might have had a horse with this arrhythmia. You might have seen or heard about another horse with this arrhythmia, because about 5% of all horses will develop AFib. Based on the information we have from racehorses, at least 5% of racehorses have AFib at some point in their career. And some of those horses will have AFib or atrial fibrillation for a short period of time, and what we call paroxysmal AFib or PAF. And that maybe means it starts and stops really quickly. Maybe in a race it'll start, and then by the time the race is over it'll finish. The episode will stop on its own. And then other episodes of AFib are longer duration. They don't stop on their own, and they need some kind of treatment to be able to stop. And so that can be kind of more tricky, and we'll talk about that a little bit more. But this is the AFib here. This is the ECG of a horse with AFib. So what you can see is an irregular rhythm. So this would sound all over the place if we were listening to it. There'd be some long pauses, there'd be some faster beats, and we can see that the actual beats themselves, they don't look too bad. They look pretty normal, but in between the beats, you can see there's all this wiggle in the background. That is the fibrillation of the atria. So instead of having P waves and nice, healthy looking P waves, we just have these, what we call fibrillation waves in the background. The next most common arrhythmia is supposed to turn up anytime soon. That'd be great. There we go, is ventricular tachycardia. So this is when we have a really, really fast rate of arrhythmia coming from the ventricles. So as opposed to the atrium, which are the small chambers at the top, the ventricles are the big squeezing chambers at the bottom. And so you could imagine if things go a bit haywire with the squeezing chambers, that can get really dangerous really quickly. And so this is just an example of how quickly things can go. This is very abnormal. You can see this kind of wiggling ECG, very, very fast. Very, very high heart rate here. And then you can see very quickly going into these smaller wiggles, and this is what we call ventricular fibrillation, or VF. This is not a survivable rhythm in the horse right now. So if a horse goes from ventricular tachycardia into ventricular fibrillation, there is really nothing we can do about that. So we spend a lot of our day trying to prevent this from happening. Because we're trying to treat the ventricular tachycardia and prevent them from going into cardiac arrest. We also see some slow rhythms. And so, we know that a lot of horses have normal AV blocks when they're at rest. That can be a normal thing that horses have. So AV block just means that the atrial signal doesn't make it to the ventricle, and so the ventricle doesn't squeeze. And we know that that can happen, about 80% of all horses will have some kind of AV block. But when you get the signals from the atrium and there's never a signal that gets to the ventricle, that's what we call third degree AV block. That can be a very dangerous rhythm. You can end up with a very slow heart rate and long, long pauses, and you can feel really poorly when you have this and sort of weak and wobbly and fall down, collapsing. And so we do worry about third degree AV block in particular, and we worry about second degree AV block, which is what we call high grade. So blocking more than we would expect, but still getting some signals to the ventricle. And the good news is sometimes the ventricle gets a mind of its own. So this horse is alive because these are ventricular signals that are kind of just enough to keep the blood supply going in a forward direction. But you're not going to feel great with this kind of, these are called ventricular escape beats. And then the last kind of arrhythmia that you might start to hear a bit more about, because we're starting to hear more about this in horses in the last couple of years, are things called accessory pathways. And these are abnormal kind of embryologic connections in the heart. So normally you don't have a lot of connections between the atria, the top chambers, and the ventricle, the kind of bottom chambers. You just have the AV node in the middle. But accessory pathways are extra pathways between the atria and the ventricles that are left behind from when you were kind of developing as an embryo. And we are discovering these more and more in horses, and we're certainly concerned about them from a safety standpoint. And we're certainly doing a lot more investigation into what these pathways, how common are these pathways, and how can we kind of treat these pathways. And we'll talk more about that in a little second. So I think of the consequences of these arrhythmias as kind of breaking down into four main categories, and what we call hemodynamic consequences, and then electrical instability. And the hemodynamic consequences, that's what we talk about with how good is the blood pumping in a forward direction. So is there enough blood getting out of the heart to go to the organs and keep the organs functioning well? And so we can certainly see plenty of arrhythmias that have no effect on the way the heart's squeezing and the way the heart's pumping that blood in a forward direction. And therefore, we're not going to see any real outward signs of those arrhythmias from the outside. So when we're looking at those horses, they'll look perfectly normal. They might just have a premature beat here or there, but the actual effect is minimal. There are definitely arrhythmias that can affect the amount of blood pumping in a forward direction. There's still some blood pumping out, but it's not maybe as much as it should be. And those horses will usually show a reduction in performance, and they'll be slower than they should be. They'll be more tired. They'll take longer to recover. And those horses will just not be performing to their expectations. But they won't necessarily be, unsafe or kind of doing more dangerous things. And then there are the arrhythmias that really affect how much blood is getting to your brain and to your muscles, and you really start to see signs that it's hard to stand up. You'll see weakness, you might see stumbling, you might see kind of partial or complete collapse. And those can be really concerning situations because there's just not enough blood getting out to the brain and to the body. And some of those can be hard. It can look like the horse is actually having a seizure because there's not enough blood getting to the brain, and the brain gets really unhappy about that. So some of these horses will actually look like they're having more kind of seizure activity, but usually the sign is that the horses that have their heart causing that will have a very quick recovery because as soon as the blood gets restored and the oxygen gets restored to the brain, then the brain is like fine again. So they don't tend to have the same kind of long period after a seizure where you kind of a bit dull and a bit not seeing so well and not yourself. These horses usually kind of snap right out of it and go back to looking the same as they looked before. And then you have the most concerning kind of outcome, which I think is the electrical instability. And if you have electrical instability, then that can be when you go from that ventricular tachycardia situation into that ventricular fibrillation situation. And those, as I say, if a horse goes into ventricular fibrillation, there's no amount of external things or drugs that we can give that stop that at this point in time. We're working on that, but we're still a wee ways away from having an ability to treat this successfully. So that will cause the horse to have sudden death, which would be really scary and potentially a very dangerous situation. And we know that about 30% of the time that a horse collapses, the rider is really seriously injured. So we also concern for the horse, but also concern for the driver or the rider, because we really don't want anyone to be injured by a horse collapsing on top of them. So we'll go back a little bit to talk now about the treatments that we have available to us. And so we're thinking about atrial fibrillation, and maybe you've never seen what that might look like as far as the heart itself and the atria kind of fibrillating. So this is a little video here that we have. We're actually doing a study of the heart in this particular video. This horse has got some catheters in its heart. You'll see that there's a couple of these white lines. We'll see in a second as the video plays that these are catheters inside the heart that we're recording the electrical signals with. And we're actually stimulating the heart, and we're trying to measure how the tissue is behaving. So we're actually doing some physiology testing here. And you'll see that when we give a certain stimulus, all of a sudden the heart becomes very irregular, and you'll actually see the atrium start to fibrillate. And so here are the normal kind of heartbeats that you can see. The tissue kind of bouncing with the normal kind of heartbeats. And then now as the atrial fibrillation starts, you'll see it kind of all of a sudden is doing like a jiggle wobble. And this is wobbling the catheters around. And this is what it looks like when the actual atrial tissue starts these little fibrillations. And so the atrium is doing usually 300, 400 of these a minute, sometimes 500 of these a minute. Thankfully, the ventricle doesn't do that many because the AV node kind of slows everything down, and you only get enough ventricle squeezing as you need. So in the horse, that's a really good thing. But the little atria are jiggling up there like a bit crazy. So what that might look like if you were exercising, for example, this is a ECG here of a horse, and this is the heart rates over time. So this horse is doing a treadmill test, and we can see here that the horse's heart rate is going up in the treadmill test and then kind of coming down. And then heart rate is going up again, and this is a pretty, hard test. The horse is working pretty hard. The heart rate is around 220. And then as the heart rate decelerates, you see all of a sudden the dots start to spread out, and this horse actually goes into atrial fibrillation here as the heart rate is coming down after the exercise test. And so then the horse actually continues on the treadmill for a little bit longer, and you can see just how much higher the heart rate is when the horse is in atrial fibrillation compared to when the horse was in a normal rhythm. And then they realize the horse is in atrial fibrillation, they stop, and then as the heart rate comes down, it actually goes back into a normal sinus rhythm. So this would be a paroxysmal episode of atrial fibrillation. So it really was like very quick to start and very quick to stop. We certainly can study the atrial fibrillation and how it starts. It usually starts with a single premature beat. So here in this example, we see a normal rhythm to the left-hand side, and then we see all of a sudden the wiggles start up, and that's our atrial fibrillation to the right-hand side. So usually a single premature beat is how atrial fibrillation is triggered. So when we're looking at premature beats, we're kind of counting how many you have per hour and per day. The more premature beats you might have at rest, the more risk you might have of developing atrial fibrillation. So we're always looking for that. And then this is that kind of more normal ECG that we see with those irregular rhythms. So big, long pauses and then faster beats here. And then the wiggle in the background is the atrial fibrillation. So a lot of horses will have very normal looking ECG. And when we exercise those horses, it can be getting more regular, but it doesn't get totally regular. So you'll see this is a horse exercising in atrial fibrillation, and we have some slightly faster heart rate here. We have narrower gaps between the beats, but it's still irregular. So if we were listening here, it would still sound a bit irregular, but not as obvious as maybe it would be at rest. And so Some horses can really do fine with atrial fibrillation and still do their job, and then other horses do more scary things with their atrial fibrillation. So this is a exercising ECG actually of a very nice, very good jumping horse, jumping 1.60 meters. And in atrial fibrillation, so really extraordinary actually that she could still do that. But electrically, this is really chaos looking. So instead of every one of these big cuirasses kind of looking the same, these cuirasses are all over the place. Some go down, some go up, some are kind of little, some are kind of big and gnarly. So this is really electrically unstable, and this is actually really fast. So the heart rate through here is in the 300s, and this horse is starting to get a little bit wobbly. This is a lunging exercise test, and this horse is starting to get a little bit wobbly. And then this is a really scary kind of atrial fibrillation where the heart rate can get very fast, and then all of a sudden you start to see that kind of wiggle wobble that we saw before that could maybe turn into the ventricular fibrillation. In this case, it doesn't, thankfully, but certainly this is very scary. And we know that about 30% of all horses in atrial fibrillation, when they exercise, can have rhythms like these last two here. So sometimes they'll look fine from the outside, but when you look at the electrical activity, it can be really kind of unstable and scary looking. So how do we tell who's good and who's not so good in their atrial fibrillation? We do an exercise test. We put them on the lunge, usually here, and we ask them to do some walk, trot, and canter. And this is the heart rates of a horse that's doing their walk and their trot and their canter test. And you can see the line at 220 is kind of the upper limit of what we think normal horses kind of get to in this, that would be high for a lunging, but certainly the upper limit of what we're kind of comfortable with. And this horse can really do his job quite fine in atrial fibrillation. So you can see here walking a little bit higher than a normal horse, but not terrible. Trotting a little bit higher than a normal horse, but still okay. And then cantering really, a little higher again than a normal horse, but really not too bad. And then the recovery here. And the ECG looks pretty fine the whole time. And so I feel pretty okay about this horse continuing to do his job, if he can do his job in atrial fibrillation. And so maybe we're not going to necessarily talk about this horse needing to be treated. Contrast that to this horse who's going out to do that very same exercise test, and instead of being really relaxed and doing fine, this horse we see it going out to the lunging area and hitting that 220, even almost 300 kind of just at the walk here. And then when we're trotting, we're definitely over 220. We're definitely approaching that kind of 250, 280 kind of at the trot. And here we briefly asked this horse to canter, and we went well over 300, and actually the fastest heartbeat here is 450, which is kind of extraordinary. And this horse is like, oh, I don't feel so good. I kind of need to slow down. And we were like, stop, because the ECG was also, looking very scary at this point in time. When that heart rate was very fast, the ECG was starting to look a little bit up and downy, which is what we don't want to see. So this horse really couldn't do his job, was feeling unwell, was not safe to do his job, couldn't do his job, and really needed to have that atrial fibrillation treated in order to be able to keep doing what he was doing. So I think when we're looking at the ones we treat and the ones that we don't treat, I think we think about if they have underlying heart disease. Is the AFib because of the heart disease, or is there really not too much going on underlying in the structure and the function of the heart look good? We don't want to treat those horses that have underlying severe heart disease. We certainly don't want to treat those horses for those when they're really close to having heart failure, because we can easily tip the medications we use and the treatments we use can tip a horse that is on the cusp of heart failure, certainly into heart failure. We start to get a little bit nervous about treating horses that have had AFib before and have now had recurrence of their AFib, because we know that the more times we treat them, the more likelihood we have of having another episode, and that usually the time between episodes gets shorter and shorter. So we might get 3 or 4 or 5 years the first time, we might get a couple of years the second time, but we might only get 6 months the third time that we try to treat these. But certainly we want to think about treating the horses that have poor performance, and we want to think about treating the horses that have these kind of scary looking heart rates and scary looking ECGs when they're exercising, because if they want to stay doing their job, we really need them to be as safe as possible. So When we're talking about how we treat AFib, we kind of have two main treatments right now. We have what we call a medication treatment, so a drug called quinidine sulfate is the drug of choice right now. And then we have what we call a TVEC, which is transvenous electrical cardioversion. So you might have heard of quinidine, you might have heard of a TVEC. And the TVEC is actually where we place catheters inside the heart and we put the horse under anesthesia and then we shock the heart back into a normal rhythm. We're shocking the atrial tissue and stopping those fibrillations and getting the heart back into a normal rhythm. And so we're often weighing up like which horses should get quinidine, which horses should get a TVEC, which horses can stay in AFib and continue to do their job. And a lot of what we, kind of decide is based on their exercise ECG and also based on their underlying kind of history. If everything looks really fine and the horse has been only in AFib for a short amount of time, and we don't have anything really scary looking on our ECG, we certainly can use quinidine, although it's getting harder and harder to find quinidine. And it's quite expensive actually now to get quinidine. So it is not as easy as it used to be able to do the quinidine cardioversions. But it's a very effective treatment. You have about an 80 to 90% chance of it working, especially in the more acute cases. And certainly it hangs around for a day or two after you give it. So it can be nice that you don't have such a risk of having a recurrence immediately after we convert them. But it does make them feel unwell, and the quinidine can make them colicky and can make them have diarrhea and can make them feel not so great for a day or two. So we really have to weigh that risk up with the reward of treatment. The TVEC, or the cardioversion with the catheters inside the heart, we'll often use that in horses where we really don't want to give them quinidine because we're worried about how high their heart rate might get. We're worried about how fast or how nasty the arrhythmias might be. If you've had the AFib for a bit longer, sometimes we think that the TVEC is a little bit more effective at shocking the heart back into a normal rhythm. And certainly, if we're worried about making the horse unwell, then we don't want to give the quinidine. And sometimes, quinidine didn't work, and so we'll try TVEC. Sometimes TVEC didn't work, and we'll try the quinidine. And so there's kind of different situations there. And then there's the situation where we don't do anything because the horse is doing its job appropriately. It's doing it in a safe way. There's nothing scary about the exercising ECG. And so we'll, in some cases, leave the horse in atrial fibrillation and say, like, let's just monitor how things are, and we kind of leave it be. So this is just a picture here of how it looks like if we are going to do the transvenous cardioversion, where we have these are the white things here are the catheters going into the heart, and we're putting them back into the heart here in very specific positions. And then we're going to hook that up to a defibrillator, and we're going to shock those atria. We're going to stop those fibrillations, and we're going to hope that the first guy who kind of comes back and recovers is the sinus node. And then hopefully a normal rhythm will take back over. And so it takes a general anesthesia, and the horse has to then recover from that. But it's again a very effective procedure, about sort of between probably 85 to 95% effective. And we can certainly restore the rhythm, but we don't have a lot of drugs on board when we do this. So there is a risk that you could have recurrence very quickly afterwards. So we sometimes will see horses waking up from anesthesia back in AFib, or within a few hours or a few days back in AFib, because there's no drugs on board preventing that from happening. So when we talk about the risks of recurrence, we always are thinking about what are the chances if we do all of this treatment, what are the chances that we'll go back into AFib? And certainly the chances are higher if we have underlying disease to the heart, if we have a big heart, if the heart has got some leaking valves, then that will increase the risk of us going back into AFib. The longer you've been in AFib, the more chance you have of staying or going back into AFib. So the more chronic cases, that's why we always try to treat these cases as soon as we can, because the heart learns how to be in AFib, and we want to try to retrain the heart and think sinus rhythm is really the way to go. Certainly, if you have a lot of those premature beats, those atrial premature beats that could trigger AFib, that is a concern for us, and what we call atrial stunning. So after we treat them, sometimes the atria take a little while to kind of come back online, and so the more stunning you have of the atria, the more risk of recurrence. And as we said before, if you've had AFib before, then having it again, certainly is of a higher likelihood. So the general rule of thumb, if we have nothing really wrong with our heart, we'll say somewhere around 30% chance of recurrence. So, 2/3 are going to be fine and 1/3 will have AFib again within about a year. But certainly my experience has been, this is a lot of data from standardbreds and thoroughbreds that had, very acute onset AFib and very short, very quickly treated AFib. And I would say the warm bloods are a bit they take a bit longer to be noticed sometimes. And so they have I find in my hands at least, the risk of recurrence is a little higher. And I would say maybe in the mid 40s to sometimes even approaching 50% chance of recurrence in the horses that have a bit more duration to their AFib. And even if they don't have anything else going on, if they've been undiagnosed for a while, then they're a bit more tricky. So I would say if you have underlying disease, so if your heart's big and you have a valve leaking, and things are not so good, then you actually increase those odds of having recurrence much, much greater than a toss of a coin. So then we really question whether we should be treating those horses. And there are some things that we try to do after we treat them to try and maximize their chances of staying in a normal rhythm. And we use some anti-arrhythmic medications. We'll often rest these horses for a period of time, trying to learn the heart back into that normal rhythm and get that normal function back. And we'll assess that function over time to see when is a good time for that horse to start exercising again. But if we put these horses back to work too soon, we're going to ask the heart to do too much, then we're going to have an increased risk of recurrence. And we don't want to have that happen, because you've just invested all this money in treating them. You really want to maximize the risk of, or minimize the risk of recurrence, maximize the chances of your horse doing well after this procedure. So now we'll switch a little bit to some of the other arrhythmias that we see. And so we said ventricular arrhythmias were particularly concerning, and these are some examples of some of the ventricular arrhythmias we see. These are exercising ECGs, where we have some early beats here, kind of wider looking kind of QRS here, and then these two very early beats that are kind of wider here. These are ventricular complexes happening at exercise, and certainly we keep a very close eye out for those because we're a little bit more worried about those. We have some slow ventricular rhythms, which are maybe less concerning for a overall kind of blood pumping around the body, but certainly we still like to keep an eye on. We see a lot of these kind of slower ventricular rhythms in our sick horses, horses that have had hemorrhage, horses that have had colic surgery, have had really bad diarrhea, really been unwell with infection. We'll see a lot of these kind of irritated myocardium, irritated heart kind of arrhythmias. And then certainly these kind of more scary arrhythmias, we don't want to see those at all. This is the ventricular tachycardia, and then, we want to try to prevent it from going into this more ventricular fibrillation story. So this is just a little quick story about one of our pet cases a couple of years ago, and he came in with a heart rate in the mid to high 200s. So he was actually around 280 when he walked in the door. And then you can kind of see his heart rate graph. We actually treated him very quickly with some antiarrhythmic medications, and we could bring his heart rate down into the sort of 230s, 240s, but we really couldn't get that rhythm to stop. And if we look at the echo of his poor little heart here, trying its very hardest, it's really doing what we call the ventricular boogie woogie. Everything is just kind of like, unable to do much because it's going so fast. And this is a really high rate for a horse to go. Probably not too bad for a cat, but really a problem for a horse. And so we tried a different kind of medication here, trying to slow his heart rate down, and you can see his heart rate really dramatically slowed here in the heart rate graph, and then all of a sudden it looks a lot different, a lot more irregular. So this horse actually went from a ventricular tachycardia into atrial fibrillation. But I was much happier with atrial fibrillation because at least the heart rate was much slower and the heart was doing a lot better in this particular situation. He ended up staying in his atrial fibrillation. Maybe he was even in atrial fibrillation before, we don't know, but he could tolerate his atrial fibrillation much better than he could when he was going like the clappers at 280 beats a minute. So when we're treating these horses, we're looking at how fast their rate is. We're looking at how stable they are. How are they colicky? Are they showing signs that they're not getting enough blood flow to their gut and to their brain and things? We're looking at the ECG, and we're looking to see how those QRS complexes are looking, and if there's any of that scary kind of wiggle that we saw before, which we call torsade de poids. And we're going to treat those much more aggressively than the slower rhythms or the well-tolerated rhythms that maybe we just need to treat the underlying disease the horse has, and those will settle down with time, which we certainly see as well. So these horses will need usually IV medications a lot of the time. So they'll need to be in hospital getting an IV infusion, and we can get these, some of these, but not all of these arrhythmias under control. Depends what the really inciting cause of them is. And it takes sometimes time for us to figure that out. So then we'll talk about my favorite little lady here, who's is my poster child for the slow heart rate. So she's this miniature donkey here. Miniature donkeys have a bit of a, they are probably a breed predisposition as well for this this arrhythmia. We do see it more in donkeys and miniature donkeys than maybe we see it in horses. But the bradyarrhythmias, or the slow heart rates, what we talked about before, those more kind of nasty looking AV blocks, the high grade second degree, and then the third degree AV blocks. So this is just a video here of her. You'll see her munching on some hay in the background, and you'll see her ECGs recording here. And we're only getting P waves now, and this is approaching 6 seconds, and then we're now kind of approaching 8 seconds, and now we're kind of approaching 10 seconds of no beats happening, just the little atrial beats, the P waves, but no big QRSs. And you see her wiggling and wobbling in the background there and getting a bit kind of dizzy probably, and her head hanging. And then all of a sudden she has a heartbeat, and she starts to feel a bit better, and she goes back to her eating. And so you can see she was having pauses upwards of 20 or 30 seconds. And usually by the 30-second one, she would actually fall down. But the 10, 15, 20-second ones, she was actually able to stay standing, but she was like really, really wobbly. And so she needed a pacemaker. And so we were able to implant a pacemaker just like we would in a dog or a human. And the pacemaker generator is here in her pectoral muscles, so in basically the base of her neck, in her chest, and just under the skin here. And then you can see this little video is of her pacemaker lead. You can see the pacemaker generator here, and then as they swing across, you can see that pacemaker lead going into her heart, and down into the heart here and screwed into the ventricular myocardium. So she had a pacemaker implanted, and she's done really well. And here she is. She wants to say how excited she is that she could get her rhythm back. So she hadn't eored, I don't think, her whole life. But once she had that pacemaker in, she felt really good, and she was much more sprightly and had a lot more blood flowing to her body and her brain, and she's done really well. We just did her checkup. I think she's 3 years now since we implanted her pacemaker, and she's doing really well. So the last thing I wanted to quickly touch on, as we're running out of time here, is accessory pathways. And some of you might know them by one of their other names, which we call Wolff-Parkinson-White syndrome. So that's WPW, some people might have heard of. And in Wolff-Parkinson-White, that's what we call pre-excitation. So that's where the ventricular signal is kind of coming very early, and so the ventricle gets pre-excited, basically. So an accessory pathway is like a bridge of tissue between the atrium and the ventricles that is not the normal AV node. And so you get left with this from the development of the heart. And you can either go down that pathway and pre-excite the ventricle, which is that what we call WPW, or you can actually go down your normal conduction system and then back up your pathway. And that can make a circuit, what we call a re-entry circuit, that can make a very fast heart rate. So this is an ECG of a horse that is actually having this tachycardia. His heart rate goes 120. when he goes down his AV node and up his pathway. And so this can obviously cause some poor performance, and makes them feel pretty poorly if their heart rate's really that high. It's not normal for a horse to kind of just stand in the stall with the heart rate 120. So we need to think about, does this horse need some medication? Does this horse need some more permanent treatment? Because this is something he was born with. Is there something we could do more permanently to kind of try and treat this? And so this is just a video of his little heart beating like the clappers with that heart rate of 120. You can really see there. Not as bad as the horse with the heart rate of 280, but certainly this is not a particularly happy heart. And so he was on some medication for a good period of time. We were able to slow his heart rate and get this arrhythmia under control in the short term, but it's not really a long-term solution to live on twice a day anti-arrhythmic medication for years and years. So we were looking for a more long-term solution to his arrhythmia. So we did actually what's called 3D mapping. So those first videos we showed of the heart signals going across the heart, we can use those same 3D mapping signals and try to find the source of the arrhythmia. And you'll just have to nod and smile and believe me here that this big red dot here with the kind of green and the red kind of joining, this is the embryologic kind of remnant of tissue that is joining the atrium from the ventricle. We can see a very special kind of a signal when we're right over that spot. This is called the Kemp potential. And these bigger red dots here are actually the ablation sites where we actually used radio frequency ablation to damage that tissue and stop it conducting. And so we put these, what we call ablation lesions. We zapped that tissue with this radio frequency ablation. And on our fourth of that, we do it for about a minute at a time. And on our fourth one of these ablations, we were able to totally stop the conduction through this area. And so far he is 4 weeks from this procedure, and he is in a normal rhythm. So he's very excited. He's a 14-year-old guy. He's probably lived with this a long time, but he is a really happy guy now that his heart rate is not 120, and also a really happy guy that he is not on twice-a-day medication to keep his heart rate from being 120. So this was a really exciting case that we just did recently. So just to kind of sum up, how do I think about safety and risk, and how do I look at these arrhythmias and put it all together? And I think I look at the type of horse that we're talking about, the job that horse has to do, the person who's riding or driving that horse, and what kind of arrhythmia it is. And then I really pay a lot of attention to the horses that have had something kind of a bit suspicious happen, like a bit wobbly, a bit weak, maybe collapsed in the pasture, particularly if they fell down while you were riding. I'm really concerned about that. I don't think you should be riding those horses. And then until at least they get checked out. But kind of putting this whole risk assessment together of like, is this something that's going to be at low speed, or is this something that's going to be at high speed? Is this, a child riding this horse or an adult who can assess the risk for themselves, and try to predict a little bit the crystal ball of what the future might hold. And so, what we do here at Cornell, we do a really thorough exam. We listen to the heart for a really long time, make sure we hear any possible murmurs and any possible arrhythmias. We record those ECGs or EKGs to see what the rhythm is doing. We'll also do a heart ultrasound or an echo to see what the structure is looking like and what the function is looking like. And we'll often measure the blood pressure as well. And then, we certainly might do exercising ECG or an overnight ECG to try and get a longer recording and a bit more information. And then there might be some blood work that we do as well, looking at the heart muscle enzymes, looking at the organs and how well they're getting oxygenated and how the kidneys are feeling, and try to put the whole story together. And as we said, we have some treatments for arrhythmias. We have some medical treatments where we're trying to either control the rhythm or convert the rhythm back to a normal rhythm. And then the idea is really in the long term that we can restore that normal rhythm and hopefully prevent recurrence of that arrhythmia from happening again. And so when we do the cardio version, we're trying to get them back to a normal rhythm. Certainly with the pacemakers, we're trying to get them back to a normal rhythm. And then the idea with this 3D mapping and ablation that's really exciting in the future, I think, of where human, cardiology is going for arrhythmia treatment, is this ablation of these abnormal tissues to try and really destroy the source of the arrhythmia and prevent recurrence. Because I think that's the future of where we really would like to go, is have these gone for good, as opposed to just have them gone for a temporary period of time. And we're often, in the background trying to slow whatever underlying disease might be going on. And so I'll just finish a little bit with one of the other electrical maps that we just got in a horse just last week. And this is actually a horse with an atrial arrhythmia, so an atrial flutter. So not quite a fibrillation yet, but what we call an atrial flutter. And this is a map of her right atrium, and you can see the electrical signals kind of moving around. The part of her right atrium this arrhythmia is called the caudal vena cava, so the big blood vessel coming from the liver and the body, back of the body, and coming into the heart. And you can see those electrical signals spreading from this abnormal area, so the opposite end of the heart to where they should be coming from. And then you can see as we turn this up, we can see that there's actually a circle here where the colors go through all the rainbow and it goes round in a circle. And this is actually the cause of the flutter. So this is where the abnormal kind of tissue is set up and made a circle. And so what we're trying to do with this is find the best spots to actually go in and ablate this arrhythmia and try to stop that circle from happening. There was actually 3 circles happening in this horse. And by blocking those circles from being able to complete themselves, you can actually stop this arrhythmia. And so she was lucky enough to wake up and be in a normal rhythm now. And she's 2 weeks since her procedure, and she's still in a normal rhythm. So we'll be monitoring her really closely to make sure that this is really gone. But again, a really exciting place for the future of not just treating the arrhythmia, but hopefully preventing it from coming back. So I think we'll finish with the arrhythmias can be very well tolerated in some horses, but there are certainly others that require intervention because they're causing a problem with blood flow or they're electrically becoming unstable. And certainly we want to make sure we find those horses that have an increased risk of an adverse event during exercise to make it as safe for you as we can to ride those horses and perform on those horses. And so we really need to do that ultrasound and the ECG, particularly the ECG for arrhythmias, to tell what's going on and look at changes over time. And I think I'll finish there with some happy photos of some of our recent patients. This is, I couldn't do any of the things that we do here at Cornell without a wonderful team. And these are some of our, well, they will call themselves cardiologists. I call them the small animal cardiologists. They are learning to tolerate horses to be able to help us out with our 3D mapping and ablation. You can see they get a bit closer. The grey mare here is the friendliest of all the creatures that we have done these procedures on. Or the donkey was pretty friendly too. So I will stop here and I will see if we have any questions from the audience.
Thank you so much, Dr. Mitchell. That was a fantastic talk. We do have a couple questions and I think just a few minutes to cover them. 2 somewhat related topics or questions that were raised was how similar or dissimilar treatment of AFib in horses is from humans. We have one attendee that mentioned that they themselves have AFib and they're on an ACE inhibitor. Are ACE inhibitors ever used for the control or treatment of AFib in horses?
Yeah, so great question. So we do, look at a lot of the human work to see what we can kind of try to take from the human side and apply it to the horse. Certainly ACE inhibitors are frequently used when there's underlying heart disease. So we'll use them if we have leaking valves, if we have, trouble with the heart getting a bit large and because of the heart disease, and we'll put horses on ACE inhibitors to try and help slow the progression of disease and try to help the heart do a better job for a longer period of time. So there are definitely horses with AFib where that is the case, where the AFib is secondary to the heart disease, and we'll try to have those horses managed. Maybe we don't try to treat their AFib necessarily, but we'll try to slow their underlying disease down. The biggest treatment in humans for AFib is pulmonary vein ablation, so what we call PVI. You might hear pulmonary vein isolation or PVI, and that's where you actually go into the left atrium and the pulmonary veins bring the blood back from the lungs, and the area where the veins meet the left atrium is a very trigger happy area, and they'll actually ablate around each of those pulmonary vein ostia, so the entries of those veins into the left atrium. And that's a really exciting area of kind of us trying to figure out how we could apply that to the horse heart. Of course, the horse heart is a lot bigger than the human heart, and a lot of the devices that we use for humans don't fit so well in the horse heart for those kind of things. But that's a really exciting area that I think we're hoping to explore in the near future, and try to be able to take care of that trigger for the AFib and prevent recurrence. So the group in Belgium is already doing it in horses, and we're about to probably do our first horse in the spring. So we're excited to try that and see if we can get it to work as well as they do in humans.
Awesome. Thank you very much. Another question, which I think is kind of commonly encountered for veterinarians and owners alike. How do you assess risk of sedating a horse that has an arrhythmia?
Yeah, so I think the question in my mind is the arrhythmia really slow? Is it a bradyarrhythmia or a slow heartbeat? Or is it a fast heartbeat and more what we call a tachyarrhythmia? Or is it kind of a horse with AFib that just has a normal, fairly normal rate, but has an irregularity to it? The ones that we worry about the most are the ones with already a slow heartbeat. So the ones with a lot of AV blocks, or what we call high-grade AV blocks. And certainly if you sedate some of those horses and then, for example, elevate the head for like a dental exam or something, you can make those horses pretty woozy because they were already slow and now they're even slower with the sedation. So we take some care with those horses. The faster ones, the ones that are really kind of more tachyarrhythmias, usually actually mostly sedation might help some of those horses out. So you have to use tiny doses of the sedation, but some of those actually do better when we sedate them because everything slows down a little bit. So it really depends on the type of arrhythmia and whether the heart's coping in behind it all. Because if the heart's barely coping and then you go and sedate them, then you might certainly make a problem. So it can be challenging.
Excellent. Thank you for that answer. I think in the sake of time, we'll probably wrap up here. If you did have a question that you'd like to have answered, feel free to reach out to us via email and we'll work to get you an answer to your question. Thank you all very much for attending this evening. Thank you, Dr. Mitchell, again for an excellent presentation, and we hope to see everyone in December.
Great. Thank you guys for attending.